Hello, this is Mrs. Condry. This is lower respiratory problems. Our objectives today is that we will compare acute bronchitis versus pertussis, and you'll be able to differentiate between types of pneumonia and treatment, discuss TB management and care, and explain the differences between pleural effusion, pleurisy, and atelectasis. Acute bronchitis is inflammation of the bronchi without consolidation of fluids. So the difference between bronchitis and pneumonia is that pneumonia has the consolidation of fluids. So 90% of bronchitis is caused by viruses, and other triggers are pollution, dust, smoking, asthma, and chronic sinusitis. The signs and symptoms of bronchitis are coughing. It's usually clear or purulent sputum, a headache, fever, and malaise. And when you assess the lungs, it might have normal or it might have adventitious lung sounds, but there's no evidence of lung consolidation. So what would be signs of lung consolidation? It might be just completely diminished bases. The treatment is usually supportive with some cough suppressants. We need to encourage fluid intake, use a humidifier, which is good in the north, but here we have plenty of humidity. So unless it's really dry out, we shouldn't need a humidifier. And the goal is to prevent pneumonia. And we need to teach smoking cessation and good hand washing and good cough technique so that they're coughing into their arm instead of their hand. Pertussis, or whooping cough, is a highly contagious infection caused by gram-negative Bacillus Bordella pertussis. The incidence has been increasing from the 1980s. Possibly from immunity from vaccines decreasing, but there's also many parents now reluctant to vaccinate their kids, so there have been more whooping cough outbreaks because of that, because of the false idea that it causes autism. The signs and symptoms of the first stage is just a mild upper respiratory infection, and the second stage is a violent whooping cough. It sounds like a crane almost, a bird crane, especially at night for 2 to 10 weeks. And then there's a third phase where there's another 2 to 3 weeks of less severe coughing and weakness. And the treatment for that is usually antibiotics, usually macrolides. In the skin section, I will be talking about what those are, which is not for several weeks. A child may even have to be hospitalized for oxygen and fluid therapy, and antihistamines and cough suppressants actually should not be used because they need to cough, they need to get that oxygen. And high humidity can be quite helpful, so often, especially at night, it's good to run a shower, bring the child into the shower, close the bathroom door with hot water, and that increases the humidity and can help them breathe better. It can be prevented with a vaccine as a child, and a one-time dose of the vaccine after age 18. Pneumonia is a bacterial infection, and it can happen when our normal defense mechanisms are compromised. There are several different classifications of pneumonia. There's community-acquired pneumonia, and this is an infection in patients not hospitalized, and they also can't be in long-term care for 14 days prior to onset. So often patients will come into the hospital and the doctors will classify whether it's community-acquired or hospital-acquired. Hospital-acquired pneumonia occurs 48 hours or longer after they're in the hospital or in long-term care. Ventilator-assisted pneumonia occurs 48 hours after endotracheal intubation. And then there's aspiration pneumonia, where so someone's eating, say they had a stroke, they aren't realizing that they're aspirating food or drinks from their mouth, or they could regurgitate it back up into their trachea or lungs, and that's aspiration pneumonia. And there's opportunistic pneumonia, which can occur with patients with altered immune systems, like those patients with HIV, or they can be receiving chemotherapy or radiation therapy, or they may be taking immunosuppressant drugs. That's termed opportunistic pneumonia, because their defense systems are compromised. So to manage and diagnose pneumonia, first, the signs and symptoms. It's a cough that can be productive. It also can be non-productive. Fever, chills, shortness of breath, tachypnea, pleuritic chest pain, where they have really bad chest pain. Elderly people can be confused, and you can hear adventitious lung sounds usually. If you don't hear adventitious lung sounds, you might just not be able to hear hardly anything moving in one area. So you might not hear, so that would be the consolidation. Testing would require a history, an exam, a chest x-ray, and a sputum culture. So the treatment is oxygen, rest, fluids, analgesics, antipyretics, and PO or IV antibiotics. Even though there's no evidence to support bronchodilators, mucolytics, which is something for to bring up the sputum, and steroids, there's no evidence to support these. They're usually ordered anyway. The pneumonia vaccine can actually help to prevent it. It's recommended at age 65 or older, or younger, 65 or younger every 5 years, if they are that age and younger. Once they hit 65, they only need one more dose, and that's it. One time or repeat dose in 5 years if received prior to age 65. 65 and older, they only need the one-time pneumonia vaccine. So complications can include atelectasis, which remember that's deflating of the alveoli, pleurisy, pain, pleural effusion, so fluid, a pneumothorax, the complete lung sac collapsing, meningitis, acute respiratory failure, which is what I talked about in the patients who had influenza back in 1917, 1918. It was actually young people that died of acute respiratory failure, sometimes within 12 to 24 hours of coming down with influenza. It was really amazing. And it can also be with someone with COPD who is not able to get enough oxygen. They can have acute respiratory failure from pneumonia. They can get septic. They can have a lung abscess. They can have pus and pyema in their lung. So I like this picture because it shows the different diseases of the lung. Here is pneumonia, where the alveoli fill with this thick fluid, and that makes the gas exchange extremely difficult. Pulmonary fibrosis will be in the next lecture, but I wanted to just show you this picture because I just love it. This is where pulmonary fibrosis is where there is the connective tissue gets very fibrous and it builds up in the tissue, so there's less elasticity. So fibrosis is where it gets fibrous connective tissue. Then the TB is a bacteria that these tubercules encapsulate the bacteria, and again the elasticity is reduced. Emphysema is where, or COPD, is where the alveoli actually burst and they fuse into enlarged air spaces. So there's much less surface area for gas exchange to occur, and that's why they get that shortness of breath. Asthma is where the airways are inflamed due to irritation, and the bronchioles constrict. So asthma is usually higher up than and bronchitis is higher up, whereas see all the other diseases here are down in the alveoli, where asthma and bronchitis are in the bronchi. So the asthma, the bronchioles constrict due to muscle spasms, so they do need bronchodilators and steroids. Bronchitis is where the airways are inflamed due to infection, and they have a lot of coughing to bring up that mucus and pus. So TB is an infectious disease caused by this mycobacterium bacteria, and it's spread through airborne droplets. So it's spread through airborne droplets, and the lungs are the most commonly infected area. 1/3 of the world's population has TB, and it's the leading cause of death in patients with HIV and AIDS. The prevalence is actually decreasing in the US, but it's increasing worldwide due to HIV and drug resistance. I was surprised at this. I thought that that it was still increasing in the US, but it is decreasing. It's spread via airborne particles. So when someone's on airborne precautions in the hospital, we have to wear the HEPA mask, the TB mask, and those have to be fitted, so students aren't usually allowed to go into those rooms. The TB bacteria can be suspended in the air for minutes to hours, but the transmission does require close, frequent, or prolonged exposure. It's not spread by touching, sharing food utensils, kissing, or other physical contact. But someone in the family who is infected, they have to be aware that they have to just be careful, take their medications. Within 2 weeks of taking the medications, the symptoms should improve. So there are different classifications of TB. The primary infection is when the bacteria is inhaled and the body initiates an inflammatory response. Most people are able to have enough of an immune response to encapsulate these organisms so it doesn't actually progress to active disease. So latent TB is after that initial exposure, when the body has encapsulated those organisms. So the patient is infected, but they don't have active disease. However, if they become immunocompromised, they can progress to active disease, and they can pass on TB to others, so they do need treatment. Active TB is when the primary TB is when the diagnosis occurs within 2 years of the initial infection. And so there are two classifications of active TB. There's primary TB, and then there's reactivation TB. And that's post-primary. It's usually over 2 years after that initial exposure, and they have symptoms. So the symptoms are a dry cough that becomes productive after some time, and they would have weight loss, night sweats, low-grade fevers, a fatigue, malaise, anorexia. But the shortness of breath is a late sign. So if a patient has had all those symptoms and then develops shortness of breath, it's a very late symptom. So there are different diagnostic studies. The first is a PPD, a tuberculin skin test. And the second is blood tests. This is more expensive, but it requires only one visit. So that in a PPD, the patient gets this injection into their forearm. I can't even get my forearm to show up in the video. But they have to come back within 48 to 72 hours to check to see if it's swollen. But the PPD is only showing that they've been exposed to the bacteria. It doesn't mean that they actually have active infection. So if either one of those are positive, then they get a chest x-ray and a sputum culture. So even though they get a chest x-ray, that it's not definitive, the sputum culture for smear culture is the definitive test. There's drug therapy for active TB. In my pharm lecture, I only focused on 2 drugs, and that was the INH and the rifampicin. Most of the other drugs are pretty similar in side effects, but they get a 4-drug therapy regimen of all those 4 drugs. And if they have latent TB, they should have 9 months of daily INH, although 6 months is acceptable. This is difficult for compliance, and it can lead to resistance if the patient is not compliant. So say you have a homeless person who has TB, it's very difficult to make sure that they're going to be compliant with the regimen. So the nursing cares, they need to be in those airborne precautions, testing and treatment, and manage their respiratory status. Pleurisy is a inflammation of the pleura, and it's caused by an infection, cancer, autoimmune disorders, trauma, GI problems, and sometimes medications. And someone with pleurisy complains of severe chest pain, and it's usually when they inhale. So as they inhale, the pleura rubs against the space, and that's what causes that chest pain. And they can be breathing shallowly, very shallow, because they don't want that rub to occur. And you may hear a pleural friction rub. A pleural friction rub is, when I hear it, I'm always excited because I don't hear it very often. Not that it's good for the patient, but I always call fellow nurses over to hear it. It sounds kind of like leather scraping. The treatment is NSAIDs, analgesics. If they lie on that affected side, it helps, and also to splint when they cough. So if they use a pillow when they cough, that will help. So how do you tell the difference when someone comes in with chest pain, if it's on the right side versus the left side of chest pain? It could be pleurisy, but it's that history. So histories are very important because we want to know, is it a heart attack or is it pleurisy? Because often it can be pleurisy. Atelectasis is a collapse of the alveoli, usually due to airway obstruction from secretions. And the signs and symptoms are decreased or absent breath sounds, or can be really dull by percussion. And we can prevent that with our teaching, with deep breathing, coughing, and using that incentive spirometer. Remember that atelectasis can not just be from airway obstruction from secretions, but it can also be like someone on a ventilator. They're not expanding their alveoli. Idiopathic pulmonary fibrosis is a chronic progressive disease with inflammation and scar tissue in that connective tissue of the lung. It's usually from smoking, but it can be from cortisone, which is one of the cardiac drugs that I talked about in pharmacology, and it's an antiarrhythmic. But if it's from cortisone, if they know what it's from, it's not an idiopathic. Idiopathic, that term means that they don't really know what caused the pulmonary fibrosis. Not just that, but idiopathic is a general term for we don't know what caused it. The signs and symptoms can be a dyspnea on exertion, a non-productive cough, the fingernails can be clubbed, they can have inspiratory crackles. The prognosis is quite poor, and the treatment is that get steroids and other immune system suppressants, oxygen. They can go to pulmonary rehab, which can teach them to conserve their energy, and if they would qualify, they might possibly qualify for a lung transplant. So pulmonary fibrosis, here are normal, the normal alveoli, and here is where they're scarred. It can often be from, like I said, smoking, from that medication. Also can be from asbestos. So that's the end of lower respiratory issues. I'll see you in the next video.